So we can start class.
Okay. Am I audible?
Sir.
Okay. Today we'll be dealing with the antithrombotic therapy in acute ischemic stroke, acute ischemic event, better term. As all of you know, in the previous classes, we learned about management of ischemic stroke in the initial phase. Initially, when we receive the patient, we should stabilize the patient and see per the eligibility criteria. If patient come within window period, thrombolize. If patient comes within tissue window period, you can plan for mechanical thrombectomy. After that, if patient comes after more than 24 hours, and for future prevention of ischemic stroke or acute ischemic events, we need to give antiplatelet or anticoagulants according to the type of stroke that happened to the patient. Mainly, the antithrombotic drugs are grossly classified as antiplatelets and anticoagulants. Antiplatelets, what routinely we are using is aspirin, clopidogrel. Rarely we use ticagrelor. And anticoagulants, both you can use your warfarin, acetram, or newer oral anticoagulant agents. Use of antiplatelets for the patient in the first days after the ischemic event is helpful to prevent the further ischemic events. Is it audible?
Yes, sir.
Hello.
Yes, sir. Audible.
Can anybody define TIA, transient ischemic attack? Anyone?
Signs and symptoms of acute infarct, which can recover in 24 hours. Less than 24 hours.
Anybody other than this definition? Anybody aware of like newer definition of TIA?
Onset within 1 hour. Onset cerebral dysfunction, completely reversible and within 4 hours, sir.
4 hours. Okay. Anybody?
So within 1 hour.
Within 1 hour. Then any other things?
I've heard of 48 hours. I heard of
24 hours, 4 hours, 1 hour.
With no radiological manifestations.
Okay, this is the newer definition of TIA. A brief episode of neurological dysfunction caused by ischemia with a clinical symptoms typically lasting less than 1 hour. And the recent addition would be without any evidence of acute infarction in the imaging studies. The newer definition of TIA is you need to do MR imaging, you need to look for DWI, ADC, and SWI sequences to look for the infarct. If patient is having infarct, even the duration is less than 1 hour, also can label it as stroke only. Okay, if patient is having like some symptoms of this kind of transient neurological dysfunction, if MRI is normal, you can label it as TIA. If MR showing any acute infarction, you can tell it as acute ischemic stroke. Okay, MRI is mandatory. Define the transient ischemic attack. This is the recent definition, 2022 AHA guidelines. Okay, kindly note it down. Okay, as a physician, you should be knowing NIHS score, aspect score, MRS score, ICH and CT volume score. I will be telling in the hemorrhagic stroke chapter, and ABCD and TOAST classifications I will tell in this lecture. Can anybody tell aspect and MRS briefly? I don't expect all the things. What is aspect, what is MRS, and what is NIHS? Just briefly tell me in a single line. Anybody? These are the basics.
So NIHS is we calculate when the patient comes to the casualty, look for the severity, and then if it is more than 6 and all, we should decide whether what treatment we are going to give, whether it is more disabling or not. Looking for
Okay.
loss of consciousness, gaze, visual, sensory,
Okay.
ataxia.
Good.
And
What is mild stroke and severe stroke?
0 to 5,
NIHS cut up or mild?
0 to 5 mild, more than
Mild
6
stroke. Okay. Good. This is the basic for NIHS. Aspect score?
for sir, to look in the CT initial CT scan, we need to see supraganglionic and ganglionic level,
Ganglion level. Good.
M1, M2, M3, and caudate, lentiform, insular area, and
Internal capsule.
internal capsule. So we
Okay.
calculate based on that 10 minus the number of areas that are involved. The lesser the score, more severe it is.
Okay, good. MRS, modified ranking scale.
MRS.
Last time I told. Anybody? Not only for stroke, you can use this for any neurological disabilities. Modified ranking scale, it contains 0 to 5. 0 means asymptomatic. 1 means mild symptoms, but he can able to maintain all his routine activities like as prior. And 2 is mild symptoms, but he cannot able to maintain his all routine activities what he was doing earlier. MRS 3 is patient needs some support like walking sticks, all those things. MRS 4 is patient dependent on the persons or 2 person. And MRS 5 is completely bedridden. And 6 is dead. Okay. MRS you should be knowing because MRS you can use it in follow-up visits also. What was the MRS in the initial presentation? What are the 3 months MRS after the follow-up? Like all those things you can be mentioned. Okay. ICH CT volume score I will teach in the next class. Okay. ICH score. We'll see ABCD and TOAST classification. These you should also be knowing. What is ABCD score? Okay. ABCD score, it contains age.
The screen is not visible.
Now? It's
No.
not visible. Now?
The slides are not visible, sir. Only first slide is visible.
It's not visible.
It's not changing, sir. Only first slide is there on the screen.
Oh. This like Ganesh iPad is there, no? Make it that one as host, okay? Samir.
Yes, sir.
Hello?
Yes,
So make it that one as host.
Yes.
Arils have shared in the WhatsApp group. You can take that PPT, okay? Someone take that PPT and share the screen. One more PPT I have shared in the group, WhatsApp group.
Okay.
So we changed, sir. Hello, sir.
Change.
Yes, sir. Now, yes, sir.
Hello, sir.
Just loading this one. 1 minute. Just a minute.
Yes.
Some it's not opening in my iPhone. Better you only share. Okay, I've shared the new PPT in WhatsApp group. Okay. Hello.
Yes, sir. 2 minutes.
Okay.
Slides are visible, sir.
Visible.
Sir, we can start, sir.
Okay. Next slide. Next. Next. Okay, this is the definition as I told earlier. So if you want to define transient ischemic attack, as per newer definition, you should get MRI done. If MRI is normal, you can label it as transient ischemic attack. If MRI showing any evidence of acute infarct, you can fit into acute ischemic stroke spectrum. Okay, as earlier we discussed, NIHS aspect, MRS score, ICS. These are the three things we already discussed. ICS scores and CT volume score will be telling in the next class. Now we'll learn about ABCD2 score, that is for transient ischemic ataxia, and TOST classification for labeling of the stroke. Okay, next slide. This is the TOST classification. Whenever you are writing the diagnosis, as in PG days we used to write CV, cerebrovascular accident. Okay, those terminologies you should not be used. So whenever you are writing the diagnosis of the stroke, first you mention duration of the stroke, that is whether it is acute or subacute or chronic. Okay, and second term should be whether it is ischemic or hemorrhagic or venous stroke. Okay, second terminology. Third one, territory, whether it is anterior cerebral artery, middle cerebral artery, posterior cerebral artery, or venous, which venous system is involved. Okay, and deficit, what are the patient having deficit, that you have to mention. And fifth one is TOST classification. This TOST classification broadly classified as large artery atherosclerosis, cardioembolism, small vessel occlusion, stroke of other determined etiology, stroke of undetermined etiology. Okay, say for an example, if a patient comes with the left MCI territory infarct with right hemiparesis, facial weakness, and aphasia, whenever you're writing the score, you write, whenever you're writing the diagnosis, you write acute ischemic stroke, left MCI territory, right hemiparesis, right facial palsy, global aphasia or whatever the aphasia we're getting, and large vessel atherosclerosis. This TOST classification you need to mention whenever you're writing that diagnosis. You define. Okay, after doing angiography, you can come to know whether patient is having large artery or embolic, cardioembolic stroke like atrial fibrillation or cardioembolic stroke, small vessel occlusion like your lacunar stroke. And even after extensive evaluation, if you don't get any etiology, you can write stroke of other determined etiology. Even after extensive evaluation, if you get any two or more causes, you can write two or more causes, and you can write negative evaluation or incomplete, patient not affordable when planning for discharge against mitigation, you can write incomplete evaluation. So whenever you're writing the diagnosis of stroke, you complete the stroke definition like acute ischemic stroke, left MCI territory, right hemiparesis, right facial palsy, aphasia, large vessel atherosclerosis, and in the bracket you need to mention NIHS. So after writing the NIHS, minor or major stroke, you need to write. Okay, this is the complete diagnosis of stroke. Okay, don't use CV like cerebrovascular vascular accident, right stroke, left stroke terms. Okay, these are all outdated. So these are the particular terminology you should always know. Okay, any doubt in this slide? Am I
Sir,
audible?
yes, sir. Sir, can you repeat the diagnosis part, sir, once?
Okay, so when a patient comes to the emergency, you diagnose the case, you write duration. First, you should mention duration. Patient, if comes with acute, like acute means almost 7 days, 7 to 28 days, that is subacute. More than 28 days, that is chronic. So you can mention this is acute stroke or subacute stroke or chronic stroke. Second terminology would be whether it is ischemic or hemorrhagic or venous stroke. Third is territory, ACA, MCA, PCA, or which dural sinus is affected or which cortical vein affected, that you need to mention. And fourth one is deficit. Whatever the deficit patient is having, hemiparesis, hemiplegia, aphasia, ataxia, hemisensory symptom, all those symptoms to be mentioned. And fifth one is TOAST classification, whether which artery is involved, whether it is embolic, whether it is atherosclerotic, or whether it is evaluated, or whether it is not evaluated, cause found or not found, all those things to be also mentioned. And last one is severity of the stroke, whether it is mild stroke or severe stroke, or mild stroke or moderate stroke and severe stroke, that also to be mentioned in the NIHS. Okay. Same in case of transient ischemic attacks, same all the things should be mentioned in the transient ischemic attacks, and territory also to be mentioned, and risk category too. Now I will tell the classification of transient ischemic according to the risk category in the next slide. If hemorrhagic stroke comes, you need to write all these things. Hemorrhagic also you need to mention duration, which territory is involved, what all the deficit patient is having, and severity. Okay. Don't use cerebrovascular accident or right stroke or left stroke in the diagnostic part. Okay. Is that clear?
Yes, sir.
Okay. Next slide. Okay. TIA, if a patient come to emergency, like 1 or 2 hours history of transient ischemic event, you have done the MRI. MRI is normal. You can label it as transient ischemic attack. So soon after you receive the patient, you calculate the score, ABCD2 score. This is okay. A means age. If patient is having age more than 60 years, you can score it as 1. If systolic blood pressure more than 140 and diastolic more than 90, you can give 1 more score. If patient is having unilateral weakness, 2 points. If isolated speech disturbance, it may be dysarthria or maybe aphasia, you can give 1 point. If duration of the transient ischemic is more than 60 minutes, you can give 2 points. 10 to 59 minutes, you can give 1 point. If patient is diabetic, give 1 point. So calculate all the numbers. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9. Total 9 score will be there. If patient is having score more than or equal to 4, this is called high risk TIA. If the ABCD score is less than 4, this is called low risk transient ischemic attacks. Okay, is this clear? Is that clear?
Yes, sir.
Any doubt you can ask, no problem. Okay, so any TIA patient you receive in the emergency, after evaluation you found to have this is TIA only, you calculate the score, ABCD score. This is for prognostication and for treatment also. Okay. Okay, patient come to the emergency, you diagnosed as acute transient ischemic attack. Okay. If already patient is on anticoagulation, just you optimize the dose. You check the INR, if patient is taking or not taking, compliance, how is the compliance, how is the INR? You see the INR, if patient is taking properly, so you can escalate the dose or escalate the dose or change the anticoagulants. Okay, day 1 only you can start the anticoagulant therapy. Okay, if patient already diagnosed case of cardioembolic stroke, already on anticoagulation, presented with a transient ischemic attack, just you see the compliance INR status and give the appropriate drugs. Okay, if patient come to the emergency, first time to the emergency, if cardioembolic stroke is not there, you calculate the ABCD score. If ABCD score is less than 4, you can label it as low risk TIA. If ABCD score is more than or equal to 4, you can label risk TIA. So in case of low risk TIA, you can give only single antiplatelet. Okay, if it is more than 4 high risk TIA, you should have to start dual antiplatelet. Okay, any doubt in this?
No, sir.
No. Okay, next slide. This is the ABCD, importance of ABCD score. Say for an example, patient come to the emergency, you calculated the ABCD score, it come around 5. Okay, the chances of getting ischemic stroke in next 90 days would be around 9.8% of, okay, 9.8% of the people will get acute ischemic stroke in next 3 months if you don't treat the patient properly. If TIA score is, if ABCD score is 3, so risk of stroke in next 90 days would be 3.1%. If TIA score, if ABCD score is more than or equal to 6, the chances of getting stroke in next 3 months would be 17.8%. So this is very important. ABCD score always you calculate for TIA patients. Next slide. Okay, let us come to the treatment part. For patients with transient ischemic attack without known cardioembolic stroke at the presentation, antiplatelets should be started immediately. Okay, because if you you evaluated, MRI is normal, if you don't get any embolic source, don't wait for anticoagulation. You start with the antiplatelet. Once you get the embolic stroke or any confirm this one is a cardioembolic stroke, that time you can shift over to anticoagulant. If low risk TIA is there, like ABCD score is less than 4, you can give aspirin 162 to 325 milligram daily. Only single antiplatelet is enough. If high risk TIA is there, like ABCD score is more than or equal to 4, if patient not on any previous treatment, you should give dual antiplatelet always, and you should give loading dose of aspirin 160 to 325 milligram and clopidogrel 300 to 600 milligram, and followed by 75 milligram of these all antiplatelet for first 21 days. If high risk TIA, ABCD score more than equal to 4, already patient is on single antiplatelet, don't load with any antiplatelet, just you start dual antiplatelet for 21 days. Any doubts in this slide? Any confusion? Clarify now only, okay? Hello?
Yes, sir.
Any doubts?
No, sir.
Okay. Next slide. Okay, next scenario, if patient is already on anticoagulation and he presented with transient ischemic attacks, okay, that time you can start anticoagulant on day 1 only. You confirm this is embolic stroke, LV clot is there, LV dyskinesia is there, atrial fibrillation is there, and MRI is normal. You can start directly anticoagulation. You can give low molecular heparin, or you can start direct oral anticoagulant. If a patient not having any valvular AF, if patient is having valvular AF, you have to give warfarin or acetram. If patient is having atherosclerosis along with cardioembolic stroke, you need to give single antiplatelet along with your anticoagulation, and don't give dual antiplatelet and anticoagulation therapy. It is always detrimental for the patient. Chances of hemorrhagic stroke will be more if you give dual antiplatelet along with anticoagulation. Is that clear?
Yes, sir.
Okay. Next slide. Okay. For a patient without any serious bleeding complication who are not on any anticoagulation or antiplatelet at the baseline, antiplatelet.
Ganesh. Hello, Ganesh.
Sir.
One
Sir,
doubt.
sir.
If patient is on, if the patient is having Veera polycythemia, Veera everything.
Okay, sir.
Even patient will put on anticoagulant for because till receiving a hydroxyurea idagomata. So
Okay, sir.
if the patient is already underwent, if he has recently underwent coronary angioplasty.
Okay, sir.
Okay, on dual antiplatelets and requiring anticoagulant. So, and in this scenario, you require triple or a double this one?
Sir, in this scenario, the expert opinion this is better you give half dose of oral anticoagulants. Say, for example, if you are giving apixaban 5 milligram BD, you can reduce it to 2.0 mg BD.
Okay.
And one scoring system is there, sir. Hess blood score, Hess blood score. You calculate the Hess blood score. If Hess blood score is 2 or more than 2, that time you should not give antiplatelet and anticoagulant together, sir. Like chances of bleeding risk will be more if the Hess blood score is more than 2. You calculate the Hess blood score. It contains, I think, ACE, PTINR, RFD, LFT, all these things that contains, sir. 5 parameters it has. So you calculate. If more than 2 is there, don't give, sir, anticoagulant and antiplatelet. If more than 2 is there, don't give. Only antiplatelet you give, sir. If less than 2 is there, half dose of your anticoagulant and your antiplatelet you can give, sir.
Okay. Thank you.
Okay. Okay, you classify. In acute, any doubt in TIA? TIA is over. Antiplatelet in TIA, that is over. Any doubt? Now only you clarify it.
No, sir.
Okay, let us come to the ischemic stroke. Okay, if patient comes to the emergency, you diagnose to have acute ischemic stroke. You calculate the NIHS. NIHS is more than 5 means it is severe stroke. If it NIHS is less than 5, it is mild strokes. You classify the stroke as mild and severe stroke. If NIHS is more than 5, don't give dual antiplatelet. Just give single antiplatelet of 162 to 325 milligram daily. Okay. If NIHS is less than or equal to 5, give dual antiplatelet at least for 21 days. Aspirin of 160 to 325 milligram loading dose plus clopidogrel of 300 milligram loading dose followed by 75 mg OD. Okay. In case of intra-arterial large artery atherosclerosis, that scenario you need to give 90 days of dual antiplatelet. Patient come to the emergency, evaluated patient has having a large MCA atherosclerosis, large intracranial atherosclerosis. That time you need to give dual antiplatelet of 90 days. Okay. Is that clear?
Sir, higher the score, we are giving only aspirin, sir. NIH score more, but we are giving only.
If NIH score is more than 5, don't give dual antiplatelet. Chances of bleeding will be more and mass effect will be more. Patient may undergo surgery.
Okay.
So in the larger the NIH score, don't give the dual antiplatelet. If NIH score is less, you can give safely dual antiplatelet.
Okay, sir. Okay.
Okay.
Yes, sir.
Okay. Next slide. Okay, after thrombolysis, you should at least wait for 24 hours. Say, for an example, patient comes within the window period, 4.5 hours, you thrombolyze with tenactipase or altiplase, and you need to repeat the CT after 24 hours of thrombolysis. If bleeding is not there, you can start antiplatelet. Okay, before 24 hours, you should not give antiplatelet. Okay, after thrombolysis, you should wait at least for 24 hours. You need to get the repeat CT done. You need to see for any bleeding like intracranial hemorrhages after the thrombolysis. If it is not there, you can start safely single antiplatelet depending on the NIH score. If NIH score is less, you can give dual antiplatelet. If NIH score is more than 5, you should give single antiplatelet. Next, this is the scenario in post thrombolysis patient. Okay, we'll continue this acute ischemic stroke only. Switch to dual antiplatelet. Patient is on single antiplatelet. He presented to the emergency with minor stroke. You shift from single antiplatelet to dual antiplatelet. Okay, and continue the existing antiplatelet regimen for more severe strokes. And duration of dual antiplatelet for 21 days in a minor ischemic stroke event and 90 days in intracranial large artery atherosclerosis. Any doubt? Next slide. Okay, let us come to the anticoagulant. Say, for example, in a cardioembolic stroke setting, patient come to the emergency, you diagnosed as cardioembolic stroke, like atrial fibrillation that is causing the stroke. In that setting, antiplatelet would not be beneficial. In that setting, you need to give anticoagulant, but starting of anticoagulation depends on your severity of stroke. If more severe the stroke, you cannot give anticoagulant directly because anticoagulant will have higher chances of converting that ischemic core to the hemorrhagic conversion. So better you need to wait depending on the NIH score. Okay, next slide. There are two rules are there. One, European or Canadian guidelines and Diner's rules are there. Most commonly used is European guidelines. Okay, European guidelines and Diner's rule I will tell in the next slide. Better use European guidelines. Okay. If you next slide. Okay, this is the European guidelines most commonly used, and this is approved in Canadian guidelines also. Like patient come to the emergency, you diagnosed a transient ischemic attack, you did the imaging, you excluded the cerebral hemorrhage, and thought to be embolic etiology. So that time you can start anticoagulant on the day 1 of your acute ischemic event. Okay, and you calculated the NIHS. If NIHS score is less than 8, you need to wait for at least 3 days. Okay, you should wait for at least 3 days. After 3 or 5 days after the stroke, you have to start the anticoagulation. And in case of NIHS is between 8 to 16, you need to wait for at least 1 week period. Then you have to start anticoagulant, ideally on the day 6. If NIHS score is more than 16 at the presentation, you need to wait for at least 2 weeks or 12 days. Then you can start the oral anticoagulants. Because if you start earlier anticoagulation, chances of hemorrhagic conversion will be more. Any doubts in this slide? This is very important in a clinical setting of cardioembolic stroke and the day of starting anticoagulants after the ischemic events. Is this clear?
Yes, sir.
Okay. This is one. This is European and Canadian guidelines says, depending on the NHS score. One more is there, Diner's rule. This is recently come. Next slide. This is the Diner rule. This is called 1, 2, 3, 4 days rule. Here he says in TIA day 1, in NHS score less than 8, day 2, in NHS score 8 to 15, day 3, and if NHS score more than 16, day 4. This is the recent trial that has concluded that even in major stroke also you can start earlier anticoagulation to prevent the recurrent stroke. So even NHS score more also you can start. Most commonly used is European guideline. This is the recent one. I think last 2023 it has come 1, 2, 3, 4 day rule. Okay, you can use this one also. Any doubts in this?
No, sir.
Okay, next slide. Okay, the general recommendation to use novel oral anticoagulants, like you divide the cardioembolic stroke as non-valvular and valvular atrial fibrillation. Okay, because valvular atrial fibrillation, all of you know, warfarin and acetram would be helpful because you cannot give novel oral anticoagulants in valvular AF. No, there are no newest trial that shown the benefit of a novel oral anticoagulant in valvular atrial fibrillation. In non-valvular atrial fibrillation or non-valvular acute cardioembolic events, you can use novel oral anticoagulants. You can choose the anticoagulants, oral anticoagulants, depending on the risk. If patient is having high risk of stroke, like high Chadwa score. Chadwa score, anybody tell what is Chadwa score? Anyone? You might have used prior.
It includes age, gender, diabetic, non-diabetic. Then,
You like you can
risk
see the
of
C
stroke,
means what? C means congestive heart failure.
congestive
H
heart
means
failure.
hypertension.
So,
A means less than
Yes.
65 one is there, more than 65 one is there.
yes,
D means diabetes.
yes.
S means previous stroke.
Stroke history.
VAS means acute vascular event in the past.
Yes.
Okay, all these course contains Chadwas 2. This is called Chadwas 2. If 2 or more than 2 is there, you need to give oral anticoagulants. If Chadwas score is less than 2 means you can give only aspirin or your antiplatelet would be beneficial. Okay, so whenever you Chadwas score is more, like Chadwas score is more than 2, you have to start anticoagulant. Anticoagulant again, it may be your newer oral anticoagulants or your older warfarin or acetram, depending on the etiology of cardioembolic stroke. Okay, if patient is having high Chadwa score, high chances of having the ischemic event in the future, you would start dabigatran. This come in 75 mg, 110 mg, and 150 mg. According to your renal clearance, you can start your dabigatran. Some of the slides are not visible. Am I audible?
Yes, sir. Audible, sir.
Okay, I'll continue. Just you share the slides. Okay. If high risk of stroke is there, you can start dabigatran. Dabigatran preparations are available in 75 mg, 110 mg, and 150 mg. You need to calculate the renal clearance. That is glomerular filtration, creatinine clearance. You need to calculate. According to that, you can adjust the dose. If patient is having previous stroke, again he is having recurrent stroke. That time rivaroxaban would be the better option. If patient is having high risk of bleeding and life-threatening bleeding, that time dabigatran and apixaban would be the better option. If patient is having severe GI symptoms, rivaroxaban or apixaban would be the better choice. If patient is having GI bleeding history, that time you can use apixaban. If any history of compliance problem, rivaroxaban would be the better choice. If patient is elderly more than 80 years, having impaired renal function, again apixaban would be the better option. Better you see the slide. This slide is very nice slide. You can use for future references. This slide indicate according to the patient characteristics, you can use the or you can choose the anticoagulants, okay, depending on the reoccurrence of the stroke, previous stroke, bleeding tendency, GI symptoms, age, impaired renal clearance. You have to look for all these patient characteristics to start the oral anticoagulants, okay. Any doubt in this slide?
No, sir.
No. Okay. Next slide. Okay, this one I think I have told in the previous class. If patient is having any ischemic stroke, later on the day of admission, if hemorrhagic transformation occurs, whether to continue antiplatelet or not. Regarding this, just you show the next slide. That slide would be the better. Next slide. So just you classify the bleed as HI1, HI2, PH1 and PH2. HI1 means only small hyperdense petechiae, small petechiae inside the hemorrhage, inside the ischemic core. And HI2 is more confluent hyperdense lesions inside the infarct zone. And parenchymal hematoma is bleed of less than 30% of the infarct zone. And parenchymal hematoma, that is PH2, is more than 30% of the infarct zone. Only in PH2 condition, you need to wait at least for 2 weeks to hemorrhage to settle. Okay, in this condition, you should not give any antiplatelets or anticoagulants. Even though ischemic stroke is there, but the hemorrhagic transformation, if it is more than 30% of the infarct core, that time you need to wait for 2 weeks. HI1, HI2 and PH1, in these three conditions, you can give antiplatelet according to the guidelines. Okay, PH2 is the contraindication for your antiplatelet. It is the slide that is hemorrhagic conversion of ischemic stroke. You might be seeing in the previous, like some of the patients before coming to the hospitals only, from the outside, they might give heparin, all those things. After coming to the hospital, that ischemic core will changes into hemorrhagic conversion. So in that setting, you need to see for this classification of hemorrhagic conversion, HI1, HI2, PH1 and PH2. So PH2 is there, don't give antiplatelet, wait at least for 2 weeks, then you restart. Okay, in above mentioned these conditions, you can start antiplatelet directly, even though hemorrhage is there. Any doubts in this slide?
No, sir.
Because these are all clinically, like you might have seen the case. At that time, you would be in the dilemma. So, okay, these are the very important slide. You should be remembering all these slides. Okay, then come to the ischemic stroke, that is secondary to extracranial or intracranial atherosclerosis, that is carotid artery stenosis, or next slide, carotid artery stenosis or intracranial large artery atherosclerosis. Next slide. It's not moving, I think. Okay. Then there is no separate difference like management of antiplatelet in ischemic stroke secondary to intracranial or extracranial vessels. Like you see for the severity of the stroke, you see for the whether it is internal, like small vessel occlusion or large vessel occlusion, same as I told earlier. Okay, but special is if patient is going for carotid artery stenting, you need to give dual antiplatelet at least for 30 days prior to the procedure. Previous slide, just previous. Previous slide, please. Okay. If in case carotid endarterectomy, only aspirin monotherapy is enough. In carotid patient is undergoing carotid artery stenting, in this scenario also you need to give dual antiplatelet at least for 30 days. Okay, after the stenting procedure. Next slide. Okay, if patient is having intracranial large artery atherosclerosis, you need to give dual antiplatelet for 90 days if the percentage of block is between the 70 to 99%. Again, if it is between 50 to 69%, according to your guidelines, like you classify as low risk TIA or major stroke or minor stroke or high risk TIA. As I told earlier, if it comes between 50 to 69% of intracranial artery atherosclerosis, you manage accordingly. If block is more than 70%, you need to give for at least 90 days. One trial has come, that is Sampris trial for intracranial large artery atherosclerosis. You should remember this trial. This trial says the management of dual antiplatelet and surgical intervention in intracranial large artery atherosclerosis. It says that you should give dual antiplatelet at least for a period of 90 days in more than 70% of blockage, and there is no need of surgical intervention in the first stroke. So you need to wait. If patient is having recurrent ischemic stroke and patient is bedridden because of the stroke, even after optimal medical line of management, that time you can take him for surgery in case of intracranial large artery atherosclerosis. Okay, this is this is by Sampris trial. Okay, Sampris trial, just you remember the name. This is for intracranial large artery atherosclerosis. Any doubt in this slide?
No, sir.
Oh, okay. Next slide. Okay, again this is same small vessel disease, or you get this like lacunar infarct. Again you classified as lacunar infarct, lacunar stroke. Again you classify as major and minor stroke events. If major is there, just use single antiplatelet. If minor stroke is there, dual antiplatelet. If low risk TIA is there, only aspirin. If high risk TIA is there, dual antiplatelet. Okay, this is the same for, this will be the same for all the kinds of acute ischemic event. Just you remember the TIA, type of TIA and type of ischemic stroke, whether it is minor or major, or a TIA, whether it is high risk TIA or low risk TIA. Next slide. Again same, this slide also same for a practical purpose. The intracranial atherosclerosis, carotid artery disease, or extracranial vertebral artery disease. Again you divide the TIA or ischemic event as a major, minor, and low risk and high risk TIA. This would be same for all the acute ischemic event. Just you remember the classification of TIA and ischemic stroke. Next slide. Okay, cryptogenic stroke. Even after extensive evaluation, if you don't get any cause, this is called as cryptogenic stroke or cryptogenic TIA. Don't start any anticoagulation in cryptogenic stroke. Aspirin is enough for cryptogenic stroke. Okay, again you say management is same. You divide as low and high risk TIA and mild and moderate stroke and give antiplatelet accordingly. Okay, next slide. Okay, regarding the antiplatelet trial, there are few trials are there. Just you remember the name. Aspirin, most like two trials, IST International Stroke Trial and Chinese Acute Stroke Trial. It shows that the aspirin dose of 160 to 300 mg, if you give in the earlier part of the stroke, it will help to prevent the fatal reoccurrence of the stroke in the future. Just you remember the name, IST and Chinese Acute Stroke Trial. Next slide. Next slide. Ticagrelor, this one is isolatedly, routinely we don't use ticagrelor because monotherapy in ticagrelor not helpful to prevent the stroke as compared to aspirin. Don't use ticagrelor in a acute ischemic stroke event. Most of the studies done on aspirin and clopidogrel. These aspirin and clopidogrel are proven drugs to prevent the stroke recurrence. Ticagrelor not much proven. Ticagrelor we routinely use in cardiac disease, acute cardiac like STEMI, NSTEMI, or acute MI. In that setting, that would be helpful. Cardiac setting, ticagrelor would be the better option, and neurological acute ischemic events, aspirin and clopidogrel would be the better option. Okay, this is done by Socrates trial. Okay, next slide. Clopidogrel, monotherapy for clopidogrel is not extensively studied prior. Okay, dual antiplatelet, yes, of course, dual antiplatelet, aspirin and clopidogrel studied extensively. Most these trials name are just you remember these name: Points trial, Chance trial, and Tails trial. These have proven dual antiplatelet benefit in high risk TIA and minor stroke to prevent the reoccurrence of stroke. Okay, don't give monotherapy of clopidogrel or ticagrelor in acute ischemic stroke. Better option would be aspirin. If you want to give dual antiplatelet, combine aspirin and clopidogrel and give. Don't give clopidogrel alone for stroke management. Any doubts?
No, sir.
Okay, next slide. Okay, don't give any anticoagulants in ischemic strokes. There are the few indications are there. I will tell you in the next slide. If ischemic stroke is there, don't give heparin. Most of the time, heparin, low molecular heparin, in some of the centers they give. Okay, there no benefit from the heparin in acute ischemic stroke. Okay, instead of benefit, it will cause hemorrhagic conversion. Again, it will cause deterioration of the patient. Okay, some of the exceptions are there. In that case, you can give anticoagulant. Can anybody tell where all the stroke situation you will give anticoagulation?
Cardioembolic strokes.
Okay. Then
Posterior circulation stroke, sir.
posterior circulation stroke. No, stroke. Acute ischemic stroke, there is no indication. Posterior circulation, if it caused by cardioembolic etiology, that time you can give. If fluctuating acute thrombus is there, patient is like worsening, deteriorating, improving, deteriorating. In that scenario, you can give. If you proven there is basilar artery thrombosis is there, that floating thrombus in the basilar artery, in that situation you can give. Other
Okay.
indication? Few more indications. Your CVT, most commonly you have seen.
Sir. Yes,
Arterial vein thrombosis will give. That is also stroke. That is venous stroke.
Okay.
And in arterial dissections also you can give. And other indications, APLA syndromes. APLA you heard, no? APLA.
Yes, sir.
APLA syndrome also you can give. Any other indications? Next slide. Okay, I told you priorly that non-valvular atrial fibrillation, valvular atrial fibrillation, and patient is on any prosthetic heart valves, patient having rheumatic heart disease with atrial fibrillation, a patient having severe cardiomyopathy of ejection fraction less than 35% and getting the recurrent stroke of embolic etiology, a patient is having left atrial myxoma, mural thrombus, LV aneurysm, and mitral valve prolapse. Not in all the cases. If mitral valve prolapse patient is having recurrent stroke even after aspirin, that time you need to give oral anticoagulant. And arterial dissection you need to give. And thrombopilias, as I told earlier, like prothrombogenic status, your protein C, protein S deficiency, primary hypercoagulable disorders. In that scenario also you need to give lifelong anticoagulation therapy. And one more is cortical vein thrombosis, or it may be provoked or unprovoked. It may be primary or secondary. In that scenario also you need to give anticoagulants. These are the indicated anticoagulation therapy in neurology. Okay, other than these conditions, you should it should never give anticoagulant therapy in other neurological cases. Okay, next slide. This I told already. Okay, acute ischemic stroke, you determine this one as a cardioembolic stroke. Just you divide whether patient is having a NIH score less than 8, 8 to 12, and more than 8. So if acute transient ischemic attack is there, you can start on the day 1 only. If minor stroke is there, better you start on day 3. If moderate stroke is there, you start on day 6. If severe stroke is there, better you wait for at least 2 weeks and restart. Okay. If large vessel occlusion, artery occlusion is there, you are planning for carotid endarterectomy, just you give single antiplatelet. If planning for dual antiplatelet, you give dual antiplatelet even after 1 month of stenting. If you found intracranial atherosclerotic disease, better you give 90 days of dual antiplatelet, then you convert for single antiplatelet. If patient is having small vessel disease, if NIH score is less, you give single antiplatelet. If NIH score is more than 3, you give dual antiplatelet for 31 days. Okay, then you shift over it for single antiplatelet. Next slide. Okay, next one is like most of the patients, like whether to start statins or not in the setting of acute ischemic stroke that is caused by atherosclerotic lesion. The target ideally would be less than 70 as your as your diabetic guidelines also. Better you keep LDL level less than 70 to reduce the future cardiovascular events. Okay, you start if LDL is more than 100 milligram per deciliter, you give high intensity statins like atorvastatin 80 mg daily at least for 3 months. Then you repeat the LDL level. If LDL is again more than 100 mg, you need to give the statins again for another 3 months. If the level is less than 70, you can reduce the dose. Okay, the ideal target would be LDL target in the stroke setting would be less than 70. Okay. Any doubts in this? Most of the time you'll use. Okay, next slide. Can anybody tell hypertriglyceridemia management? Any guidelines you are aware of? Routinely you see in the OPD and admission patient. How will you treat hypertriglyceridemia? When will you treat hypertriglyceridemia? Can anybody tell? Any exam going pieces? Okay, next slide. BP, ideally BP should be maintained less than 130 80 mm of Hg to prevent the future attack of stroke. Better you use ACEs or ARBs. If needed, you can use diuretic also. These are the class 1 recommendation. BP should be less than 130 80, your target BP, and ACE ARBs are the drug of choice to prevent the future vascular events. Next slide. Any role of neuroprotectives? So neuroprotectives, like not commonly used. These are all the like marketing. Most of you like ceticolin, pyracetam, nicergolin, ginkgo biloba, beclotus. Multiple marketing teams will come and they will tell to write the prescription because there are no proven role for neuroprotectives. Only proven role that is indicated in aphasic patient are hypoxic myoclonic drugs. In that setting, you can give these neuroprotectives at least for 3 months. Other scenarios, they are not proven role. Okay, don't use neuroprotective. And for hypertriglyceridemia, if patient is having triglyceride level less than 500 mg, there is no need to treat. Just you advise the diet and give omega fatty acid. If triglyceride level is more than 500, that time you need to treat with your fibrates. Okay, don't treat all the hypertriglyceridemia cases. Okay, if more than 500 only, you treat. Next slide. This is a newer drug that has come in the market that is called sovalitide. This sovalitide drugs, this is endothelin antagonist, endothelin receptor antagonist that will lead to vasodilation. It will increases the blood flow to the ischemic core or ischemic penumbra tissue. So it will improve the outcome of cerebral vascular events. So sovalitide is a newer drug. We are also started using. It should be started within 24 hours of the acute stroke setting. Dose would be around 0.5 micron per kg. This would be given in a BD dose, day 1, day 3, and day 5. This has proven. I think phase 2 results are also come and drug has also come. 2 or 3 patients we also use this drug. Okay, it has good results also. Sovalitide. Okay, you remember the name. This is a newer drug. Next slide. I think over. Okay. Any doubts in the management of acute ischemic events?
No.
Sandeep sir,
Ganesh,
ಏನ ಡೌಟ್
ಏನಿಲ್ಲಪ್ಪ
ಕನ್ಫ್ಯೂಸಿಂಗ್ ಏನಾರ ಇತ್ತಾ ಇದು
ಏನಿಲ್ಲ ಕನ್ಫ್ಯೂಸಿಂಗ್ ಏನಿಲ್ಲ ಇಟ್ಸ್ ವಾಸ್ ಗುಡ್ ಟಾಪಿಕ್ ಇಟ್ ವಾಸ್ ಗುಡ್ ಟಾಪಿಕ್ ಮೆನಿ ಥಿಂಗ್ಸ್ ಡೌಟ್ ಕ್ಲಿಯರ್ ಆದವು
ಓಕೆ
ಗುಡ್ ಟಾಪಿಕ್ ಭಾಳ ಡೌಟ್ಸ್ ಇತ್ತು ಕ್ಲಿಯರ್ ಆಯ್ತು ಯಾಕಂದ್ರೆ ಮೋರ್ ಆಫ್ ಥಿಂಗ್
ಪ್ರಾಕ್ಟಿಕಲ್ ಆಸ್ಪೆಕ್ಟ್ ಭಾಳ ಇದೆ ಸರ್
ಪ್ರಾಕ್ಟಿಕಲ್ ಆಸ್ಪೆಕ್ಟ್ ಭಾಳ ಇತ್ತು ಆಮೇಲೆ ನಾನ್ ದಿಸ್ ಒನ್ ಇದು ಭಾಳ ಕ್ಲಿಯರ್ ಇದೆ ಭಾಳ ಪ್ರಾಕ್ಟಿಕಲ್ ಆಸ್ಪೆಕ್ಟ್ ಭಾಳ ಇದಿತ್ತು ಬಟ್ ಎವ್ರಿಥಿಂಗ್ ವಾಸ್ ಕ್ಲಿಯರ್ಡ್.
PGs, any doubts? Ask me. Antiplatelet, when we are doing MD days, we are having a lot of confusion regarding antiplatelet, when to start, what to give, what not to give, when to give. Okay. You asked if you have any doubt, okay, regarding antiplatelet or anticoagulants.
Ganesh, it is a good cover. Okay, everything
Okay.
was doubt covered agate.
Okay, sir.
Everything, whatever we face the practical issues.
Okay, sir.
It has been this one. These things should not be given in the books. But
Sir.
new age
Sir, it's difficult to cover in MD books.
the physical MD books, it is very much difficult
It
to
is
cover.
difficult.
But whatever this one treatment clinical point of view, everything is covered
Okay,
a
sir.
lot. ಯಾವ್ದೋ
Okay, sir.
ಏನ್ ಡೌಟ್ ಇರಂಗಿಲ್ಲ. We
Okay,
can
sir.
easily manage and we can easily put the drugs ಇದು ಬರ್ಬೋದು. With help of your this one flowchart ಐತಲ್ಲ, ಆ flowchart
sir.
ನಾಗು it is well and given everything. It
sir.
explains everything in one
Last time I had
flowchart,
given one chart, sir. Overall stroke. It was good
stroke,
actually.
It was good. One
One of my
flowchart
senior
we
made
can
that one.
ಇಲ್ಲ that is very good. If you attach in that one in casualty where you work ಅಲ್ಲ, just
That
we
would
can
be
go
better,
through
sir.
ಮಾಡಿದ್ರೆ we can I tell our PGs implement because when we start implementing only ನಾವು ಬರಿಬೋದು ಈಗ.
We'll learn, sir.
ಇಲ್ಲಾಂದ್ರೆ we never write it in our daily practices. We just go through like only old CVA, left this one, that one. But what you told that diagnosis, it was very good.
Sir.
ಯಾಕಂದ್ರೆ if we start practicing now only, we
You cross
continue
check, sir.
will
Sir, you cross check next time onwards. Your
ಅದರ
thesis.
ನಮ್ದ ತಪ್ಪದ
You cross check the diagnosis, okay? Whether they are writing or not writing.
ಕ್ರಾಸ್ ಚೆಕ್ ಮಾಡಕ್ ತಪ್ಪದ. ಯಾಕಂದ್ರೆ ನಾವು ಅರ್ಜೆಂಟ್ ಆಗಿರ್ತೀಯ, ಮೇಲೆ ಏನ್ ಕೇಳ್ತೀಯ, ಇಟ್ ಇಸ್ ಅವರ್ ಮಿಸ್ಟೇಕ್ ಓನ್ಲಿ. ಬೀಯಿಂಗ್ ಎ ಸ್ಟಾಫ್ ವಿ ಶುಡ್ ಇದು ಮಾಡ್ಬೇಕಿತ್ತ. ಯು ಹ್ಯಾವ್ ಟು ಡೂ ಇಟ್. Thanks, Ganesh. It was a nice and thanks a lot.
Okay, sir. Thank you, sir. Next class will be like CVT will cover cortical vein thrombosis. I think that is the most commonly we are getting this cortical vein thrombosis. Next week we'll plan for this.
Okay.
Samir, you better generate ID like Wednesday, Thursday, Friday. Okay.
Okay, sir. Yes, sir.
Like Monday, Saturday would be busy. Today also, like I went by 3:15. I went for lunch. It was busy. So better you plan on Wednesday or Thursday, Friday next week.
Yes,
cortical vein thrombosis. Okay, CVT.
Yes, sir, I'll contact you before generating, sir.
Yeah, one day before you tell me so that I can also see the slides.
Okay, sir.
Ganesh, ಇನ್ನೊಂದು
sir.
ಜಸ್ಟ್ ನಮ್ PGs ಗೆ ಏನಂದ್ರೆ symptomology of each systemic lobar, okay, ಆಮೇಲೆ
ನಾನು ಹೇಳೋ ಪ್ರಕಾರ ಬೆಟರ್ ಕೇಸ್ ತಗೊಂಡ್ ಮಾಡಿದ್ರೆ ಲೈಕ್ ಯಾವ್ದೋ ಪೇಷಂಟ್ ನೀವು ಒಂದ್ ಯಾವ್ದೋ ಡಿಮೆನ್ಷಿಯಾ ಏನಾದ್ರು ತಗೊಂಡ್ರಿ, ಪಾರ್ಕಿನ್ಸನ್ ತಗೊಂಡ್ವಿ ಅಂತಂದ್ರೆ ಅಲ್ಲಿ ಅಟ್ಲೀಸ್ಟ್ ಒಂದು 5 ರಿಂದ 6 ಸಿಂಪ್ಟಮ್ ಬಂದೇ ಬರ್ತವೆ ಸರ್. ಆ ಟೈಮಲ್ಲಿ ಡಿಸ್ಕಸ್ ಮಾಡ್ಲಿಕ್ಕೆ ಚೆನ್ನಾಗಿ ಅನ್ಸುತ್ತೆ.
ಈಗ ಸ್ಟ್ರೋಕ್ ಮುಗಿದ್ಮೇಲೆ ವಿಲ್ ಟೇಕ್ ಒನ್ ಸ್ಟ್ರೋಕ್ ಕೇಸ್ ಅಂಡ್ ಲೆಟ್ ದೆಮ್ ಪ್ರೆಸೆಂಟ್.
ಅಲ್ಲ ಸರ್, ಎಕ್ಸಾಮ್ ನೋಡಿ ಅವ್ರಿಗೆ ಎಕ್ಸಾಮ್ಗೆ ಯಾವ ಕೇಸ್ ಇಡ್ತೀರಾ ಬೆಟರ್ ಅವನ್ ತಗೋರಿ.
ಈ ಎಕ್ಸಾಮ್ ಅಷ್ಟಂತೂ ನಾವು ಸ್ಟ್ರೋಕ್ ಇಡಂಗಿಲ್ಲ.
ಅದೇ ಸ್ಟ್ರೋಕ್ ಬೇಡ ಅವ್ರಿಗೆ. ಸ್ಟ್ರೋಕ್
ಅಂದ್ರೆ ನಾನೇನಂತೀನಿ ಲೆಟ್ ದೆಮ್ ಹ್ಯಾವ್ ಎ ಟೆಸ್ಟ್. ಇಟ್ರೆ ಮುಂದ ಅಕಸ್ಮಾತ್ ಏನಾರ ಅವ್ರಿಗೆ ಡಯಾಗ್ನೋಸಿಸ್ ಹೆಂಗ್ ಬರೀತಾರ, whether they covered all LNSs. This we can revise what you thought ಅಲ್ಲ, whether they have done ಅಂತಂದ ಒಂದ್ ಐಡಿಯಾ ಸಿಗತ್ತೆ ಇಷ್ಟ. whether they have done ಅಂತಂದ ಒಂದ್ ಆದ್ಮೇಲೆ ಒಂದ್ ಸ್ಟ್ರೋಕ್ ಮಾಡೋಣ. ಆಮೇಲೆ ನೆಕ್ಸ್ಟ್ ಅಗೇನ್ ವಿಲ್ ಸಿ ಲೈಕ್ ವಿಲ್ ಕೀಪ್ ನಮ್ಮ ಇವ ಇರ್ತವೆ ಅಟಾಕ್ಸಿಯಾ, ಸೆರೆಬ್ರಲ್ ಅಟಾಕ್ಸಿಯಾ, ಕ್ವಾಡ್ರಿಪ್ಲೆಜಿಯಾ, ಪ್ಯಾರಾಪ್ಲೆಜಿಯಾ ಅವನ ಬಾಳ ಇರ್ತಾವ.
ಅಂತ ಕೇಸಸ್ ನೋಡಿ ಯಾವ ವಾರ್ಡಲ್ ಕೇಸ್ ಇದ್ವು ಅಂದ್ರೆ, ಯಾಕಂದ್ರೆ ಸ್ಟ್ರೋಕ್ ಅಲ್ಲಿ ಬಹಳ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಅಲ್ಲಿ ಬಹಳ ಡೌಟ್ಸ್ ಇರ್ತವೆ. ನಾನು ಪಿಸಿ ಟೈಮ್ ಅಲ್ಲಿ ಬಹಳ ಸ್ಟ್ರಗಲ್ ಆಗಿದೆ. ಸೊ ಅದಕ್ಕೆ ಇವನ್ನೇ ಟಾಪಿಕ್ ಸೆಲೆಕ್ಟ್ ಮಾಡ್ಕೊಂಡಿನಿ. ಸ್ಟ್ರೋಕ್ ಅಲ್ಲಿ ಸಿಕ್ಕಾಪಟ್ಟೆ ಡೌಟ್ಸ್ ಇದಾವೆ. ನೋಡೋಣ. ಸ್ಟ್ರೋಕ್ CVT 1 ವೀಕ್ ಆಗುತ್ತೆ, ಒಂದು ಇಂಟ್ರಾಸೆರೆಬ್ರಲ್ ಹೆಮರೇಜ್ 1 ವೀಕ್. ಸೊ ಸ್ಟ್ರೋಕ್ ಆಲ್ಮೋಸ್ಟ್ ಮುಗಿಯುತ್ತೆ ಅಲ್ಲಿಗೆ. ಅದಾದ್ಮೇಲೆ ನೋಡ್ರಿ ಮತ್ತೆ ಯಾವ ಟಾಪಿಕ್ಸ್ ನಿಮ್ಗೆ ಬೇಕಾಗುತ್ತೆ ಆತರ ಪ್ಲಾನ್ ಮಾಡಕ್ ಬರುತ್ತೆ. ಎಪಿಲೆಪ್ಸಿ ಬೇಕು, ಅಥವಾ ಮೂವ್ಮೆಂಟ್ ಡಿಸಾರ್ಡರ್ಸ್ ಬೇಕು, ಅಥವಾ ಕಾಗ್ನಿಷನ್ ಡಿಮೆನ್ಷಿಯಾಸ್ ಬೇಕು, ಅಥವಾ ಏನ್ ಕೇಸ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಬೇಕು ಇಲ್ಲ ಪರ್ಟಿಕ್ಯುಲರ್ ಯಾವ್ದಾದ್ರು ಲೈಕ್ ಮೋಸ್ಟ್ ಡಿಫಿಕಲ್ಟ್ ಏನ್ ಅನ್ಸುತ್ತೆ ನಿಮ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಥೇರಿಗಿಂತ ಸರ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಆಸ್ಪೆಕ್ಟ್ ಫೋಕಸ್ ಮಾಡೋಣ. ಈಗ ಎಟಿಯಾಲಜಿ ಪ್ಯಾಥೋಜೆನೆಸಿಸ್ ಅವೆಲ್ಲ ಬುಕ್ಕಲ್ಲಿ ಓದ್ಕೊಂಡ್ರೆ ಬಂದ್ಬಿಡುತ್ತೆ ಅವ್ರಿಗೆ. ಸೊ ಮೋರ್ ಆಫ್ ಪ್ರಾಕ್ಟಿಕಲ್ ಆಸ್ಪೆಕ್ಟ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಅಲ್ಲೇ ಪ್ರಾಬ್ಲಮ್ ಆಗುತ್ತೆ ಅವ್ರಿಗೆ.
ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಆತ. ನಾನ ಈಗ ಎಕ್ಸಾಮ್ ಅಲ್ಲಿ ಸಿಂಟಮಾಲಜಿ ಆಫ್ ಪೆರಿಫೆರಲ್ ನ್ಯೂರೋಪತಿ ಆಫ್ ಅಟಾಕ್ಸಿಯಾ, ಈಗ ಆಮೇಲೆ ಇದು ಅವ್ರಿಗೆ ಅಪ್ರೋಚಸ್ ಹಿಂಗ ಹೇಳ್ಕೊಟ್ರ
ಅದೇ ಅಪ್ರೋಚ್
differentiating
ಮಯೋಪತಿ, ನ್ಯೂರೋಪತಿ, ಪ್ಯಾರಾಪ್ಲೇಸಿಯಾ. ಸೊ ನೆಕ್ಸ್ಟ್ ಮಾಡೋಣ ಅಂತ ಸರ್ ಅಷ್ಟೇ.
ಮಾಡ್ಕೊಂತ ಹೋಗೋಣ. ಇಟ್ ವಿಲ್ ಬಿ ಈಸಿ ಫಾರ್ ದಮ್ ಎಕ್ಸಾಮ್ಸ್ ಆಲ್ಸೋ. ಕೇಳ್ಕೊಂತ ಹೋಗ್ಲಿ. ಓಕೆ,
ಹಂಗೇನಾದ್ರೆ ವಾಟ್ಸಪ್ ಅಲ್ಲಿ ಗ್ರೂಪ್ ಅಲ್ಲಿ ಹಾಕಿ ಸಮೀರ್.
Yes, sir. Yes, sir.
WhatsApp name, if you have any doubt, like if you want particular topic, if you are facing any management aspect problems, just you text me on the WhatsApp group so that I can prepare. That would be
Okay,
better.
sir. Yes,
Okay,
sir.
stroke I think another 2 weeks will cover.
Okay,
So
sir.
next month onwards, better you like choose the topics that you are facing routinely in your
Yes, sir.
OPD or admission time. We'll
Yes,
talk
sir.
about that. Like if you go on telling, it will take 1 or 2 years to finish this important topic. So better
Yes,
you
sir.
decide whatever the problems like you are facing in your institute. So you take those topics and text me in the group so that you can address those things.
Sure, sir. Yes, sir. Yes, sir. Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Thank you, Ganesh. Good night.
Good night, sir.
Yeah, Arti. Yeah.
Samira, how to save that recorded?
Switch off recording. मतलब
I'll
stop
pause that
recording
recording.
दबा.
Stop.